Now it's time for refreshments. Tea is ready, and after at 11:30 there will be a lecture by Colonel Dr. Yusuf. Lecture is by Dr. Jegathesan. There is a big story behind this course. Last year I was in Maldives and I met Dr. Jega. He is the Chairman, Medical and Scientific Commission, Olympic Council of Asia. And at that time I asked him that we want this course in Pakistan also. And he promised with me that Dr. Wakar will give you a course in Pakistan. And it was solely his efforts that this course was located in Pakistan. So thank you, Dr. Jega. And now he is coming to deliver his lecture. IOC Medical Code. Can you all hear me without a mic? No problem, huh? Over there? Okay, so I think it's more informal and more convenient just to chat like this, if you can. But anytime, if you can't hear me or you want to stop me for a question or a clarification, feel free to do so. You want to make this interactive and informal, we are all colleagues, so it would be nice if you just get into a friendly atmosphere. The main thing is to impart what we messages we want to pass to you. At the same time, we want to get to know you and to make you feel part of this whole broader Olympic family. Right? So, as mentioned earlier, I'm very happy that we were able to get this course to Pakistan. Just a little bit of commercial for you. How does this come about? Now, the International Olympic Committee, as you know, is the owner and guardian of the Olympic Games, which is held every 4 years, Summer Games and the Winter Games every 4 years. And now they also have the Youth Games every 4 years. So 3 major games they do. And they have, of course, it's become a world blockbuster, and they collect quite a lot of revenue from television and other things. And so that they can use this money to promote sports all over the world, especially in countries which are growing and developing. They created an organization called Olympic Solidarity. So you see over there, Olympic Solidarity is the arm which is formed, it's like a foundation, formed out of the earnings and profits of the International Olympic Committee, so that it is looked after and the money is used to promote sports events such as this. But as you can imagine, with over 212 countries or something like that, having to share all of this, it's very competitive. So every year you have to make a bid to get money for Asia. And even in Asia, we have 45 member countries, so we have to find an equitable way of distributing the support. So Pakistan has not had a chance to conduct a course like this for some years, so we made a strong case, and the IOC Olympic Solidarity, is very happy to support it. That's why we are doing this course here. So basically, it's part of the IOC Olympic Solidarity program. And one of the compulsory lectures in this series is the IOC Medical Code, because we need to make all participants aware of what is the IOC Medical Code and what it means within the Olympic movement. Now, basically, we want to promote sports as a philosophy, as a nation builder, as making friends, all the good things about sport. I'm sure we all agree about the good things in sport, but at the same time, a lot of bad things have also slowly crept in. Started with the big money, and so today what do we have? We have athletes taking drugs, we have athletes, sports people fixing matches, we get all kinds of things. So somehow we have to get on top of this. But at the bottom of this, I think we must never forget what the Olympic Games stands for is the spirit of Olympism. So we should never forget that, and the IOC Medical Code is drawn up on the basis of a fundamental belief in the spirit of Olympism. And basically, what does it do? It aims to protect the health of athletes, prevent illness, injury, and psychological harm during training and competition. Now, as you can understand, top-level competition today is very serious, very strenuous. Athletes spend whole day maybe training to be world champions, They push themselves to the limit of physical capability. And as doctors, there's a limit to what we can take. There's so much of overuse, stress, and so on. So in fact, not just from the physical point of view, there's always the element of the caregiver also over stressing the athlete, whether it's a coach or even the doctors sometimes, they push athletes beyond their frontiers. And all of this can have an effect. So basically the medical code tries to protect the athlete through this entire process of preparing an athlete for top-class global competition. So we know the dangers, and we try to put this medical code in place so that at least we will minimize these dangers and have checks and balances that will allow this thing to be done in an orderly fashion such that the athletes are protected. The next important thing is protects athletes in the relationship with healthcare providers. As you know, the obligation of healthcare providers to patients. All of us who are medical practitioners here, we take the oath of Hippocrates. We sign all kinds of ethical declarations with our governments, our ministries of health, our medical associations and so on, and we conduct our behavior according to an ethical code. I think doctors are driven by this. So now, when it comes to athletes, sometimes the medical personnel are under different kinds of pressures. Pressures from leaders in sport, pressures from politicians, pressures from political leaders who want victories, who want gold medals, who want to make name for the country and so on. Push the athlete, doesn't matter, let him drop dead after this, we don't care, but let's get the gold medal, So that kind of things, and sometimes the healthcare provider can be in a position, where he can unduly influence the athlete beyond his medical practice. So this is a special kind of stress that we have in sports. Alright, so the medical code also looks at the relationships that are between the provider and the athlete, who's the patient, and safeguards this such that the provider does not go beyond the boundaries of honest and ethical medical practice, where the welfare of the athlete should transcend and be most important other than any other consideration. So can you now get the picture of the whole philosophy behind this IOC medical code? Now, what are the principles? Basically, athlete-centered. The health and the welfare of the athlete comes first. Again, when we ask medical students or anybody, who's the most important person in the hospital? Of course, when they are naive, they'll say, the director, or they'll say the owner of the hospital. But we all know, and we teach them, who's the most important person in the hospital? Exactly. All of you answer like a choir, all right? Because we are trained that way, So again, when it comes to sports, we forget, we think the president is the most important, or the council, or the executive board, But really, what is sports all about? In the end, no athletes, what sports you want to have? The president's hospital are patient-centered. Here we have athlete-centered. The health and the welfare comes first. And the protection of athletes' rights and privileges with respect to healthcare and the relationship with healthcare providers. Issues of consent, private and confidentiality. Now consent, again very important. We take a lot of things for granted. In a hospital, you wouldn't operate on a patient without getting his consent, would you? And yet, in a field and athlete, we simply do anything we want with them. Why? Because sometimes there's a sense of urgency, sometimes there's pressure. So again, don't forget this thing about consent. Although you are the team doctor, the athlete is your patient, don't forget, first and foremost. So anything you do to him, you have to give him information and get informed consent. If you're giving him an injection, if you're giving him a surgical procedure or a medication, you have to explain to him and ask him, well, are you happy to take this, So that's something we need to do. And next thing is privacy. Again, top athletes are high profile personnel. Everybody is keen on them. You and I can die tomorrow, nobody cares. But if an athlete's big toe hurts, the whole newspapers want to put it as a headlines. And they will make big stories about this. So again, you need to maintain this confidentiality. You are the last person who should be telling stories to the opposition will use this. I mean, in bouts like taekwondo and so on, for instance, if an opponent knows exactly which part of your body is weak, I mean, they will target you there, So we have to keep all this very confidential, especially in the face of a very active press. The paparazzi, what do you call them? Paparazzi, who follow around, wanting to know everything. And confidentiality, Again, confidentiality, not only to the press or anything, even to higher officials in the organization. Your respect of the athlete's confidentiality comes first. some official may ask you, hey, what's wrong with this guy? You know, so you must know how to handle that. Then the duties and obligations of healthcare providers, I think that is quite clear. And the application of best practices for medical care and services. Now, sports medicine in many countries is a growing field. It's not as well established as other disciplines, you know. So maybe in many things we don't yet have well accepted consensus on what is called medical best practice. It is evolving, but yet, you know, if you're going to practice, it's your duty to sort of learn this and apply the best practices. And what is the scope of this IOC medical code? It applies to all Olympic Games. I told you we now have summer, winter and youth. And competitions of the regional Olympic associations. So who are the regional Olympic associations? These are the continental organizations, like all of us here. We come under the Olympic Council of Asia. So the Olympic Council of Asia is the regional Olympic organization. And so we carry the Olympic ideas and the Olympic program, everything to the 45 member countries of Asia. So any competition within our region, like you have sub-regional games. I think Pakistan is involved in the SAF games. I think every 2 years. Right, I come from Malaysia, we have Southeast Asia games. Then those in the Gulf, they have Gulf games. And then, you know, Hong Kong, China, and Japan, so on, they have the East Asia games, and so on. So all those games are also controlled by this. Okay. Now, what are some more of the principles? Athletes have a right to full information of all the medical issues involving them. That, you know, this is where I talked about informed consent as well. Huh? You need to give them all the information. A lot of treatment in sports medicine gets to the realms of sometimes mumbo jumbo, you know, meaning that, you know, there are a lot of myths and pet things that people do to them, and sometimes they just defies explanation. Literally, huh? Boxing is one of the few sports where the ringside doctor makes the decision, you know, and he's given the power. But unfortunately, you don't get this in games like football or hockey or anywhere. The doctor can't stop a game. You know, he can only advise. In the boxing, you can, but in these other sports, you can only advise. But you have control on your player. You may not have a control on another player on the field, but you certainly have control on your own player. And if you are called in to look at your player during the game and you have decided he should come out, you must be able to resist the pressure from the coach or somebody who likes it to go back in. So you must make your medical decision and be firm about this. I think this is very important. We have seen all kinds of instances where sometimes the doctors are pressured so much that they let their clinical judgment be overruled by the pressure of the moment. So this is something you will acquire through practice and through being very firm all the time, and eventually people will know you. Don't play around with this guy. No, I mean, he knows his job and he's very firm. Okay. In training, the athlete's health takes priority. So again, you know, you're a team doctor during training. Coach wants to push for whatever reasons. If you know medically that that's not wise, you put your foot down. So these are your responsibilities. Okay. And the IOC medical code prescribes this and gives you the authority and the power to institute this within your organization. Appropriate safety precautions must be met during training and competition. I think, you know, for competitions, it's not a big issue. Like all these big games, we've got our guidelines and so on, and organizers have to prepare all of this. You know, they need to have the first aid, they need to have emergency things, they need to have ambulance and so on. But don't forget, training is just as dangerous as a competition, you know, and we tend to neglect this. We don't prepare for these during training times. So we also need, maybe you don't have all of those on track or on the side, but at least you should know where you can quickly access them. And basic resuscitation things you must have. You know, as a team doctor, you will have access to them. Now this is the other thing, the obligation to provide appropriate medical support during events, competition and training. I mean, for these, like the Olympic Council of Asia, we have drawn up a medical guidelines where the basic medical level of services for all the different sports has to be put there. And we have categorized sports into high risk, medium risk and low risk. As you can imagine, some sports are very high risk. You need the highest level of support. And some are low risk. I mean, like if we have the chess competition, I mean, you know, you don't worry too much about it, you know. But you have some support. So you don't worry too much about it. So we have, now we have so many sports in the Asian Games. Last Asian Games in Guangzhou, we had 42 sports including chess. That's why I mentioned chess. We even have doping testing during chess. Okay. So it happens. So anyhow, that's how it is. So now, coming back to the IOC medical code. So what are the main objectives of this code? First of all, it recalls the basic rules of best medical practices in sport. Okay, it reminds all the doctors, all the medical personnel, what are the best medical practices in sports. Second, it protects the right and health of the athlete. And third, go to the games. But they cannot control governments. Now, governments have to sign a UNICEF declaration, and not all governments have signed. So if the government has not signed, they do not want to punish the Olympic Committee or the athletes by not allowing them to come to the Olympic Games. They are allowed to come. So how do they teach a message to the governments? Yes. If your athlete is allowed to come to the games, but if the government didn't sign the UNICEF declaration, if the athlete happens to win a medal, they will not fly the flag or play the anthem. They will use the Olympic anthem or the Olympic flag. So that's the only way they can send a message to the countries who don't want to become signatories to this anti-doping code. Now the IOC medical code also, every NOC has to become a signatory to provide all of this. Alright, so these are the two parallel things that are going side by side. And next, it reflects the general principles recognized in the international codes of medical ethics. So they have adopted, you know, there are a number of international medical codes of ethics, the World Medical Association and so on. So they've taken the best of all of that and created their own ethics. Okay, this medical code, IOC medical code, was first adopted by the IOC Executive Board on the 27th of October 2005 and brought into force by the IOC on 1st December 2006. And it was revised, in 2009. And from that time onwards, the current code, 1st October 2009, the current code is in place. Now, where can you get this code? Any of you can go into the Olympic website, olympic.org, and you find a link there to IOC medical code. You can download it, print it, do what you like. It's all there. So you have full access to it, so I won't repeat it here in its total. A list of signatories will be made public by the IOC, and the new version is expressed as a series of goals and objectives as opposed to formal legal obligations. Complaints procedure clause has been deleted, and all members of the Olympic movement may choose to adopt, distribute and monitor the compliance of the new version, including to what extent they may wish to impose sanctions on the persons within their jurisdiction who do not respect the terms of such a code. So in other words, there's an element of voluntarism in this. NOCs can decide how much of the code they want to adopt and what kind of sanctions they want to put on medical personnel who don't follow the code. Alright, so each country has to determine how they will handle this and how they will apply this on all their medical personnel. Right? Now, just a quick outline of the chapters and so on, which, as I said, you can download from the IOC website. Basically, the first one is on relationship between athletes and healthcare providers, talks about the issues of consent, confidentiality and privacy, and the care and the treatment. Secondly, protection and promotion, simply because they've not really had a proper pre-participation examination. Some sinister thing they had was never revealed, and when stressed, they dropped it. So that is an issue that's coming up. And then, of course, medical support during competitions. Then another chapter on the adoption, compliance and monitoring. So this describes how NOCs can adopt the code, how they can see whether they comply with it, and how they monitor this. And it's a responsibility of NOCs to do all of this. And also the scope, the entry, and the amendments. Okay. Now, how do you adopt this for NOCs? IOC first adopts the code that was done. Not mandatory, but desirable that all members of the Olympic movement adopt it. So then we send it out for signatories. Many of our NOCs have signed, and according to your own policies, statutes, and procedural laws. Now, medicine in countries is governed by their own laws, code of ethics and so on. Every country has got its own laws. So the IOC code has got to tailor for that, because you cannot supersede a country's laws. You can't bring some code from outside that supersedes the law of the country. So you have to work within that. And our country's laws and medical practice varies in the 45 countries. So we can't have a single way of doing this. communication and encouragement between signatories and physicians, workers to work in accordance with the code. Ethical and professional rules remain respected in addition to the code. And the most favorable rule that protects the health, rights and interests of the athletes should prevail whenever there is disagreement between the national law and the athletes. The IOC Medical Commission oversees the implementation of the code and receives feedback relating to it. So now if any of you go back and look at the code and try to use it and you have any difficulty or parts that you don't agree with, you can always send back feedback through your NOC. Now you remember the code first, I said, came in 2005 and they amended it in 2009. The amendment was based on feedback from people like you all. Alright, so there will be another round. So the next few years they'll collect feedback and maybe around 2013-14 or something they will revise it again. But that's how, it's a dynamic document, it's not carved in stone. You know, nothing remains the same. Alright, so feedback from all of you will be very welcome. You know, and feel free to send back any feedback you have. If you find difficulties with any part of the code. So where do you find the code? As I said, it's on the website www.olympic.org. You go into IOC, then you go to the commissions, go to the medical commission. So in the fourth level of link, you find the medical code. Okay. I think you will circulate the PowerPoints to this presentation. You can circulate to all the members, right? So you'll have all of this. So don't worry about copying. Yeah, so you can send it to them or you can print and give it. Okay. Now this is the second part of my presentation. Since Pakistan is a member of the Olympic Council of Asia as well, so I'm going to tell you about some of the activities of the OCA Medical and Anti-Doping Commission, which I'm chairman of. Now our OCA, Olympic Council of Asia, has got its headquarters in Kuwait. It's a very impressive headquarters. Some of you may have had the opportunity being there, and it operates out of that office. And we have 45 member countries, our NOCs. The most heterogeneous group in the whole world. You know, you find so many different ethnic groups, maybe 1,000 languages, I think, maybe 10,000 dialects, you know, and from the richest to some of the poorest countries in the world are also within this region. Yeah? And so, you know, it is quite a challenge to have a family bringing them all up together and trying to move them all in one direction. It's quite a challenge, but very interesting one. And so we have also sub-regions. We divided them to West Asia. West Asia, as you know, is most of the Arab countries. Then we have East Asia, which is China, Japan, Korea, Mongolia, Hong Kong, Macau, Chinese Taipei, that group. Then we have South Asia, which is your grouping. Pakistan. Pakistan I think is in Central Asia, whereas South Asia is with. So you are in Central Asia. South Asia is Nepal, India, Maldives, and so on. Southeast Asia is Malaysia, Singapore, Philippines, Indonesia, and Central Asia is the Stan countries. Kazakhstan, Uzbekistan. So you are with them? All right. No, I think you are in South Asia. You are in South, isn't it? South Asia. South Asia, right? South Asia.
Games in South Asia, but in the WADA, we have been put in Central Asia.
So there's a difference, because I think within the Olympic movement, you belong to South Asia. That's why you're part of the South Asia Games. But when it comes to the WADA, because WADA I think goes under the World Health Organization, the United Nations. So for UN purposes, I think Pakistan belongs to the other region. So yeah, so I think that's why it is there. Yeah. Okay. Now each of these regions have their multi-sport game. So you have your SAF. Have you hosted before SAF games? Where? Islamabad? Twice? When was the last one?
2004.
I see. Okay. So and when is the next SAF game?
2012.
Yeah. So every 2 years you have that. Now, as far as the OCA is concerned, we have a number of regional games. For the regional Olympic bodies, we have the most number of games. We have our 4-yearly Asian Games. The last one, Guangzhou. The next one will be in Incheon, 2014. This is the biggest one. It is our main games, Asian Games. Then we have the Asian Winter Games, also 4 years. The last one was 2011 in early last year in Kazakhstan. Then we have the Asian Indoor Games, which is supposed to be every 2 years. So the next one will be in 2013 in Incheon. It will serve as the test event for the main Asian Games. The Asian Beach Games is unique. Beach Games is only held in Asia. Maybe we have a lot of sunshine and sand, okay? But we are the only continent with the Beach Games. It's very popular and no shortage of hosts. The last one we had was in Muscat. Some of you were there. And then the next one is going to be in a few months' time in Haiyang in China, in June. All right. And then after that it will be in Phuket, so on. So very popular. Then we have the Asian Junior Games or Youth Games. Now, ever since the Olympic movement started the Youth Games, they started the Asian component, and the policy is to hold the Asian Youth Games 1 year before the Olympics, so that your youth can be selected and sent. So the first first Youth Olympics was in Singapore in 2010. So we had the first Asian Youth Games in 2009 in Singapore, and the next Youth Games is going to be in 2013 in Nanjing, 1 year before the Youth Olympics in Nanjing in 2014. Then we had the Asian Martial Arts Games in 2009 in Bangkok, but now they've decided to amalgamate it with the Asian Indoor Games. So you'll end up with 5 games in every 4-year cycle. Okay? Now these are just some of the logos, Guangzhou and Muscat, Singapore, Almaty. Now for the organization, for the OCA, the president is Sheikh Ahmad Al Fahad Al Sabah. He's from the Kuwaiti royal family. He's the president of OCA as well as the IOC member, and so he's a well-known sports official. Then we have the executive board, and we have a director general who runs the day-to-day business of the organization, Captain Hussein Al Musalam. And then we have various committees, and the ones concerning us here will be the medical committee and the anti-doping commission, as well as the anti-doping department. There is an anti-doping department in the Kuwait office, which has got full-time staff, and the man who was running it, who contributed a lot to the anti-doping movement in Asia, Mr. Mahmoud Al Khalifa, unfortunately passed away of a heart attack last November. And so, there will be somebody to come and take over, but he made a lot of contribution, and it was quite a loss to this anti-doping movement. Some of you would have met him in your activities. This is our committee here, and we have what you call representation. When we choose this committee, we choose obviously on expertise, on experience, but also to ensure that there is representation on a regional basis. So every year this committee is elected, every 4 years. The last election was in 2011 in July at the OCA General Assembly in Tokyo. Every NOC is free to nominate a candidate. Alright, so Pakistan Olympic Committee is free as any other NOC. So if any of you are aspiring to be members of the medical committee, get the NOC to nominate you for the next round. You're most welcome. And there's a selection process and a voting process, which will try to ensure that the best people are selected and will serve OCA for the next 4 years. So we have quite a good representation from all the regions. And to look after anti-doping matters, we got an anti-doping commission. Now the anti-doping commission is not by election, it's by appointment by the president, because they want to make sure that the people who are put into this anti-doping commission are really fully versed with the what we call all the anti-doping WADA codes and all the processes and so on. This was the anti-doping department. Basically, the functions of the OCA Medical Commission is to lay the guidelines for medical services and anti-doping program for the Asian Games series. Remember the 5 Asian Games? So we determine the level of medical services and anti-doping program in each of these games. I'll give you an example. For instance, in Guangzhou, we had 11,000 athletes. Can you imagine looking after the medical care of 11,000 athletes over this 2-week period, playing in 42 games, in 55 venues, spread around the whole of southern China? Can you imagine the medical challenge? And every country who hosts these games during the period of the games, from the time the games village opens until the closing ceremony, they have to provide free first-class medical care to every registered person in the games. You've got 11,000 athletes, we'll have another 5,000 officials. So you're handling 16,000 people, you know, and to provide first-class, fast-track, medical service, quick, because the media is also watching. Can you imagine a fallen athlete on the field and nobody responds for 5 minutes? It will be on all the world television, including CNN and CNBC. Okay? You know, within half an hour, it will be on all the TV about this guy lying down there and nobody attending to it. You know, so can you imagine the impact these days? Huh? So it's quite a burden on the host country to be able to provide this kind of medical service. And to give you examples, I mean, some very dramatic things have happened. You know, people have had renal operations, they have had heart operations, all kinds of things during games. What can you do? I mean, some of our officials, senior people, they get a heart attack during the games, they get stents put in, they get bypass, whatever. So any of these things can happen, you know. On the offset of it, we also have requests for a lot of elective things, you know, which is not encouraged. I mean, somebody will come and show you a mouthful of caries which he has not done anything for the last 6 years. But he turns up in Guangzhou and he says, "Can you fix my teeth?" You know, so you get this sort of thing as well. You know? So I mean, there are rules to protect that. Then we supervise the above services through dialogue, constant dialogue. Maybe throughout the 4-year period, maybe 1,000 emails. You know, a lot of phone calls, a number of pre-games site visits, maybe every year, especially nearer the games 2 or 3 times. And during the games itself, on-site supervision. For example, if any athlete, official or somebody is admitted to a hospital during games time, one of our medical commission members will immediately go to the hospital, visit the athlete, make sure that everything is being done, talk to the doctors, talk to the director, and make sure that everybody is satisfied with what's being done. So these are the kinds of things that we do. Then during the games itself, for anti-doping, we do the results management for the anti-doping rule results management group, who will sit and decide whether an anti-doping rule violation has occurred and inform the discipline committee and so on and so forth. Then apart from this games time, we assist with sports medicine courses, such as your course here. So we will, if you ask us for speakers and so on, we put you in touch with speakers and recommend them for you. And we work with the IOC Medical Commission on its activities, and we coordinate with the World Anti-Doping Agency and RADO. You all may know what is RADO. RADO is the regional anti-doping organization. So for you, you have a RADO, yours will be Central Asia. Whereas there's also a RADO, although your games is South Asia, there's a South Asian RADO in Maldives, you know, and so those other countries will be working with them. There are now altogether 15 RADOs in the world, of which 5 are in Asia. And recently, in January, we had a gathering of all the RADOs in the world to see how they're doing at Kuwait. There was a global assembly of RADOs. Again, some of you might have been there. This just to tell you another thing that we give information. This is a little bit out of date. This doesn't exist anymore, but there are similar ones, you know. If you went into the website of the UK anti-doping, or the USADA, or the Norwegian, or the Scandinavian anti-doping agencies, you can go to drug information bases. So why are these important? This allows you to search whether any drug, as a doctor, you're giving to an athlete, whether any drug is on the ban list or not. Because you are sometimes caught in a position where you got supplies of your medications from your government, you know. They supply you the medications through your ministry or the government pharmacy. You're keeping there and you're going to use on your athletes. Now, you got to be very careful, because you should not be the one who has been the cause of a drug failure, you know. So you want to know what you're giving, whether it's on the ban list or not. And these drug bases will give you within seconds. If you put in either the generic name or the proprietary name, if you put into the website, it will tell you within seconds whether it's on the ban list or not. So if it's on the ban list, what you do? Either don't use it if you can, you got an alternative, or if you insist and you have to use it because the patient needs it, then what you do? You create a TUE, a therapeutic use exemption. You're allowed to do that. But you have to justify why you couldn't use something else, so that process is another method. But I'm just drawing attention to the fact that within seconds, as long as you've got internet facilities, within seconds you can find this out. So try not to make a mistake like that. Now, this is the OCA guideline for the medical services and anti-doping program. Purpose is to assist the Asian Games organizing committees in each of the host cities, and is a document that goes on and we support during these games. So basically, what are the host city obligations? So like for instance, if you host the SARC Games, what are your obligations? Firstly, the obligation is contractual. Every host city signs a contract with the OCA, and the contract will say what you must deliver and so on. So part of it in the contract is already the medical service anti-doping is there. So you have to give the contract according to the contract. So that's legal. The second one is conventional. Conventional meaning in medical practice we have common sense and we have good practices. So even though it may not be in the contract, we expect a medical practitioner or a medical service to provide that within internationally accepted conventions. All right? So there are practices. And the third one is promotional. What do we mean by this? When you host, it's your chance not just to deliver the games, It's your chance to also showcase your country. And not just showcase your country from the tourism angle and all that, but even from the point of view of the excellence of your medical services. That's your opportunity to really show how good your medical service, how fast is your response, how good are your specialists and so on. So use this as an opportunity, really. Because like I said, you've got organizing Asian Games, you're going to get 11,000 athletes, and you're going to get thousands of medical encounters over the 2-week period. Maybe 50 hospital admissions and thousands of medical encounters. So it's an opportunity, and they'll all go home and talk about it. The media will talk about it. If a top athlete is admitted to a hospital, the media is going to ask him, are you treated well? Is everything going well? Are you better now? So all this is good promotion for the country and its medical services. Okay, so with that, I finish my talk for today, and I'll be happy to take any questions or comments. Yes, please. Yeah.
There was a comment which you mentioned, confidentiality and privacy. What is the difference between confidentiality and privacy?
Okay. Now, privacy is something that happens at any moment in time when you're dealing with a patient. At that point in time. For instance, a patient wants to see you, then you have to do it privately, not in front of his teammates, in front of the coaches and so on. Obviously, simple thing is asking you to talk. I think I explained it here. And of course, you can, you just have a look at it in front of everybody, is okay. But if you really want to do a proper history-taking, medical exam and so on, then you have to do it in privacy. That is the privacy part. In other words, you must allow the athlete to be able to speak his mind, because it is privately, it is with you. But sometimes in front of a coach, believe me, a lot of athletes in front of a coach, they're scared. For whatever reasons, they're scared of coaches and so on. And that's a different kind of relationship. So if you ask an athlete in front of his coach, how bad is it or not, he may not tell you. Whereas, so that's why you must exercise this concept of privacy and say, look, excuse me, I would like to talk to the athlete by myself, and I like to examine him by myself. So that's a privacy part. So that's in that moment in time. The confidentiality is something that can stretch for even years. Even after 2 years, you can come and say, no, he was really not injured that time, or something of that sort, or tell the press what is the extent of his injury, or otherwise, or when you think he's going to recover, all these kind of things.
In case of an athlete, if there is a disease which has no direct effect on his performance for the time being, but later on, it will have an effect on his health. Are we supposed to tell the coach or the sports managers about it?
Okay. Now this again is very individualized. You must go on a case-by-case merit. All right. Now the first thing is you have to decide medically what you're going to do. Your decision is let him continue competing. Now if you have the full competence to do that, fine. But if you felt you need a second opinion from a specialist in a particular area, you have a duty-bound obligation to actually, get a colleague in, but of course all confidentially between doctors. You refer him to your colleague, ask a second opinion. I think it's a good thing. Especially some of us are generalists. We may be an endocrine issue, it may be a malignancy issue, maybe something of that sort. So you might want to get a second opinion. Again, fully within our parameters of medical consultation. Nobody else outside should know. Between you, the specialist, and the athlete. Okay. So now after that, if you want to now take certain action, in other words, if you want to recommend that the athlete should not continue, although he's well now and all that, but because of some future danger, this is what you will do with an employer. Like for instance, when we are on the panel to examine employees. Now, how do you handle the information to the employer? Again, you only on a need-to-know basis. What they need to know, you tell them, not anything more. So you have to individually decide at that time how much you can tell. See, because there are things that you don't want to go out. For instance, it may be something to do, and again, basically you've got to get the consent of the patient again.
That's why it's difficult, because for the medical ethics, like you see, we have a direct relation with
Yes,
the patient,
yes,
and the patient, and the employer is not our contact.
exactly. But again, the employer may need to know on a needs basis, and if anything you want to reveal to the employer, in this case, let us say the officers or the employers you get the consent of the patient to say that for your sake, I'm going to let them know this. But again, you put it in a confidential way and tell them that this is not for public dissemination. It is. I agree with you. It is a difficult thing, and no two cases are the same. Each one has to be case managed. There's no strict rule or protocol to checklist to just sign off. So you've got to manage it, and it can be a very sticky thing.
I already discussed about to select the committee member from the NOC. So I just want to know what is the criteria to select a person for the doping control as a doping control officer or and that purpose. Is therefore also especially for the developing countries where they have no chance to gain more experience.
Okay. Now let's separate the two things. One is to be a medical committee member is usually a person who is senior enough, who has done quite a lot of work in his own country, who may be a leader within his own country. He could be a chairman of his NOC's medical committee. You need to have that kind of status, to be nominated to come into the OCA medical commission. In other words, we are thinking of somebody who's been 10, 15 years in the field, leading committees and so on. So you need to be that kind of a person. And then of course, again, when the names come in, they look on a regional basis, look at suitability, experience, and we also try to get a spread of expertise. We like some orthopedic surgeons, some dental specialists, some psychologists, and so on. We try to get a spread of expertise as well, so that our committee has got a balanced. So those things are for the member of the medical commission, all right? But that is not to preclude. Everybody has a chance. So if you have a good people, don't hesitate to nominate, because we like to see, the best people come forward. It's not a club that you're keeping closed and not wanting people to come in. So please feel free to nominate. We welcome that. Okay. Then of course we have a selection process. Now we come to the second part. The second part is now in the anti-doping program. I didn't mention because, like I said, this was mostly about the medical code, not so much about it. Tomorrow I may talk a bit more when I talk about the update on doping. Now, you remember I mentioned the 5 Asian Games we have, and we do the doping control program there. And the local committee is to arrange for the doping control program. Like for instance, in Guangzhou for the Asian Games, they do 1,500 tests. So 11,000 competitors, 1,500 tests. Something like more than 15%, something like 10-15% of the athletes are tested. When we have indoor games, 2,000 athletes, we do 300 tests. All right. Beach games, 1,500 athletes, we do 200 tests. So that's the sort of ratio, all right? So for these 200 tests, you need the personnel. So who are the people whom we need? We need the actual people experienced in managing the collection of the specimen, keeping within the security of the specimens, holding them and doing the chain of custody and sending it safe to the accredited laboratory. Some countries have the laboratory within country, otherwise you've got to send by courier and air and everything, So all that has to be managed in a secure manner. So those people are called doping control officers. And of course, for each group there's a leader, so we call a lead DCO, you know. So each country will have to train people and have that. So how do we do this, you know? Every 4 years once, we know all the host countries who are going to be organizing a game. So we conduct a host country workshop, and we invite 5 to 10 people from each of the host countries, where we give them a course, you know, we get experts to come in, give them a 4-day course on doping control. So they will have attended this WADA course. WADA has got a toolkit for training DCOs. It's a 4-day course. So anybody who wants to be a DCO should have attended this course. So that's your first entry point. So they will be the hosts. But what we want to do, and we are following this strictly in OCA, is for every Asian Games that we have, we apart from the host trained DCOs, we insist that they have what we call international DCOs, so that we portray a level of independence, you know, not just all host officials. You know, can you imagine, say for instance in China, all the doping control officers are Chinese. Say organized in Korea, all are Koreans, you know. So a little bit, you know, athletes may feel like, you know, I don't know whether I'm being treated fairly or not, and so on. So we inject international doping. For the big Asian Games, we have 10. And for the smaller games, we have 5. And we select them from the regions, and we try to make sure that they look as foreign as possible. For instance, if the SAF Games is in Sri Lanka, we don't take a Sri Lankan from Singapore and send him there. No, because he will look like the same. So we try to find a Chinese, you know, or a Korean or a Uzbekistan. So at least they can see some foreign-looking faces, not just faces, languages also. Suddenly now an athlete can only speak Russian. You know. And we're all running around helter-skelter trying to find somebody who can speak Russian. So at least if you have a DCO from Kazakhstan, you can quickly call him, maybe even on the mobile phone, talk to the guy, you know, find out what he's saying. So we also try to find these language groups within the 5. So our main languages here we worry about are usually Russian, because many of our countries are Russian speaking. You know, all the STAN countries, they are basically Russian speaking. Even Mongolia, Vietnam, and North Korea are also Russian speaking. So we like to have 1 or 2 Russian speakers. Arabic, of course, we need somebody who speaks Arabic. Then Urdu or Hindi or, you know, all this. So we try to get a mixture. Okay. Now how do you become this international DCO? We appoint them. So how do we appoint them? We appoint them, first of all, they should have attended one of these recognized courses, which allows them to have the basic knowledge. Secondly, they should start to create a record of activity within their country. In other words, they organize the local national athletic championship, doping control. They create a CV of activity. Then these names are collected by us and we select. You know, so once you select, then of course it depends on how you perform, how you get along as a team player, and so on. You may get invited again and more often. You know, so certain people will become, you know, they build a reputation for good work. So that's how it is. So basically, coming back, try to attend one of these courses. Now, there are a number of these courses going around. WADA organizes them, RADOs organize them. So try to attend a RADO course at least. Then you get a certificate to say that you've attended this WADA training course. Then after that, you can be nominated by your RADO. So you can be nominated to us by your RADO, by WADA, or by your NOC, based on whether you set this course and whether you're doing work in the country. Then we pick up the name. So right now, we have on our register about 25 names. So and this register is growing. So we welcome newcomers and we give them a chance. You know, based on, as I explained, language, ethnicity. Yeah. So for instance, like in Korea, we'll be picking many people from this region because they won't look like Koreans, right? And they can speak other languages other than Korean. You know. So that will be the way. We wouldn't pick somebody from extra people from China and Japan and all that because the athletes won't know the difference, you know. So we want to show an international workforce, you know, so that the athlete feels, I can speak to somebody in Arab, I can speak to somebody in my language, you know. At least that comfort feeling, you know, that they are being understood. So that is the function. And it's working very well now. Working very well. Yeah.
So is there any consent form?
No, we go usually by, you know, each local, yes, because each local have got their own language, you know, as your consent form in your country will be according to your medical code. within the country, you see your practice. So as long as you follow the laws of your country. Anything else? Okay, thank you.
Thank you.